Ischemic heart disease is a leading cause of morbidity and mortality in resource-rich countries. For the millions of patients affected by it, the origins of the disease are entirely invisible, causing no symptoms as the underlying damage slowly accumulates. The foundation for a heart attack does not begin with a sudden onset of chest pain. The first physical evidence of atherosclerosis, the disease process that creates the blockage, can actually be found in children between 10 and 14 years of age. Atherosclerosis is a chronic inflammatory process. It is driven by complex interactions between plasma lipoproteins, leukocytes, and vascular endothelial cells, rather than a sudden accumulation of debris clogging the plumbing. This animated cross-section shows the first physical stage of the disease, known as the fatty streak. Inside the layers of the artery wall, a thin, yellow streak consisting of smooth muscle cells and foam cells filled with cholesterol begins to form along the major arteries. Heart attacks, therefore, are the final, violent symptom of a structural failure that has been quietly compounding within the vessel walls for decades. Over time, the fatty streak develops into a fibrous plaque, projecting into the vessel and physically narrowing the lumen. At the complicated lesion stage, the structure reaches its breaking point. The plaque ruptures, activating the coagulation cascade. A dense thrombus forms, completely sealing the pathway. With the blood supply suddenly cut off, the internal chaos manifests externally. The patient experiences severe angina, breathlessness, extreme fatigue, and in some cases syncope or fainting. These clinical symptoms are alarm bells indicating a critical lack of oxygen to the heart muscle. The immediate medical challenge becomes locating exactly where in the dark vascular network the structural failure occurred. This early wooden electrocardiogram machine highlights our long history of tracking the heart's electrical pathways. Today, a 12-lead resting ECG remains the baseline test to catch the faint electrical whispers of ischemia and identify previous tissue damage. However, a resting ECG is not necessarily abnormal, even in the presence of severe multivessel coronary disease. When the baseline electrical readings offer no clear answers, doctors must escalate to stress testing. Using echocardiography, cardiologists evaluate physical ventricular function. Real-time three-dimensional reconstruction allows them to spot abnormal wall motions brought on by physical exercise or pharmacological stress, identifying areas where the muscle is struggling. This early scanner illustrates the leap in engineering required to see inside living tissue. Moving to cellular-level diagnostics, tools like cardiac MRI and PET scans measure myocardial perfusion, allowing doctors to precisely differentiate between permanently scarred tissue and viable, salvageable myocardium. Non-invasive scans successfully prove whether the heart is dying. Saving it, however, requires high-resolution geographical coordinates of the blockage. Selective coronary angiography provides the highest resolution mapping available. Often combined with intravascular ultrasound, it allows doctors to accurately diagnose the exact location, extent, and severity of the coronary stenosis. This topographical map traces the left main coronary artery arising from the aortic root. It branches into the left anterior descending artery, or LAD, the most frequently diseased vessel. Because it is the primary supply route, significant stenosis carries the worst survival prognosis. Expanding to the right side, we trace the right coronary artery passing anteriorly and wrapping around the margin of the right ventricle. Whether this artery or the circumflex artery supplies the posterior descending artery determines the patient's anatomical dominance, a vital detail for surgical planning. Angiography establishes a strict mathematical threshold for surgical intervention. Any stenosis that reduces the artery's diameter by more than 70% is classified as severe. Once the vascular network is mapped and the severe blockages are pinpointed, the medical team possesses the exact blueprint needed to execute a physical bypass of the damage. This historical image anchors the era before precise bypass techniques were perfected. In the 1950s, surgeons attempted to augment flow to the myocardium through crude methods, such as creating pericardial adhesions, yielding very limited success. By the 1980s, treatment rapidly evolved with less invasive percutaneous coronary interventions, eventually leading to the widespread use of bare metal and drug-eluting stents to prop open narrowed vessels. Despite continual advances in stenting technology, Recent large multi-center randomized trials consistently confirm that coronary artery bypass grafting remains the gold standard operation, particularly for diabetic patients and those with severe high-risk disease. The bypass procedure relies on harvesting a healthy vessel from the patient's own body, most commonly the internal mammary artery or the saphenous vein from the leg. This diagram shows the harvested vessels surgically connected, creating a physical bridge. It routes the blood supply directly from the upper aorta to a clean point on the artery past the blockage, entirely circumventing the severe stenosis. Ischemic heart disease quietly builds compounding obstructions over a lifetime. By deploying an escalating series of high-resolution diagnostic maps and executing masterful surgical engineering, medicine bypasses the damaged structures and successfully rewrites the heart's anatomy to restore the flow of blood.
If you like this video, give us a thumbs up